Welcome to this specialized episode of our medical education series. Today, we're undertaking a comprehensive, deep dive into one of the most ambitious public health endeavors in the world, the system of early intervention, EI, for childhood development in India. For junior residents, this is foundational knowledge that informs your approach to every pediatric encounter, and for experienced clinicians, it offers a crucial lens to understand the systemic context and profound challenges underlying child health outcomes across the subcontinent. The clinical relevance of this topic cannot be overstated. We are not just discussing a government program, we are analyzing the structure designed to influence the neurodevelopmental trajectory of approximately 270 million children. The operational framework is an unparalleled effort at scale, characterized by its reliance on multi-sectoral coordination, primarily achieved through the Rashtriya Bal Swasthya Karyakram, RBSK, and the Integrated Child Development Services, ICDS. This episode will be your authoritative guide, bridging the ambitious policy goals with the complex realities on the ground. We will cover the neurobiological rationale for intervening early, dissect the legal and legislative mandates, walk through the three key components of the service delivery model from primary screening to tertiary care, and finally, offer critical insights into the systemic impediments and strategic recommendations for improvement. Foundational rationale, the neurodevelopmental imperative. To understand the immense investment and mandate behind early intervention, we must first appreciate the scientific underpinning, the concept of the critical window in early brain development. This is not simply a nice idea, it is a neurobiological reality. The dynamics of early brain plasticity. The national commitment is validated by a robust understanding of the unique plasticity of the developing brain. The sheer pace of development is astounding. During early childhood, especially up to the age of 3 years, the central nervous system undergoes a period of massive reorganization. Neuronal precursors proliferate to form about 100 billion neurons, and, crucially, each of these neurons develops an average of 15,000 synapses within those first 3 years of life. Developmental milestones, the very building blocks of a child's future, are underpinned by this intense neuronal plasticity, which allows the brain to reorganize networks in direct response to environmental stimulation. Think of it like laying the foundation and wiring for a skyscraper. Experience acts as the construction manager. Frequently used synaptic pathways are strengthened, like installing high-capacity fiber optic cables, while less used connections begin to atrophy through a process known as synaptic pruning. Periods of rapid developmental progress directly correlate with phases of significant synaptic change in the associated brain regions. The profound clinical takeaway is this: the timing of intervention is the most critical determinant of efficacy. A delay in diagnosis and intervention until later childhood, after this peak period of synaptic reorganization, makes remediation significantly less efficient. The emphasis on early detection is thus driven by the neurobiological reality that the optimal opportunity for influencing brain architecture is maximized during these sensitive periods. Conversely, sensory deprivation during this critical time can have long-lasting functional and structural consequences that are incredibly difficult to reverse. Mitigation of toxic stress and adverse experiences. Early intervention serves a secondary but equally vital function as a neuroprotective shield against the impacts of chronic psychosocial adversity. We know that early influences, including systemic disadvantages such as poverty and discrimination, can result in high, unbuffered exposure to stress, which is clinically referred to as toxic stress. This prolonged exposure isn't just a social issue, it's a biological one. It leads to physiological dysregulation, or allostatic load, which negatively affects key biological systems. The result is altered brain connectivity and persistent dysfunction in the stress response system that can last a lifetime. This toxic stress can even influence gene expression through epigenetic changes, like DNA methylation, without altering the underlying DNA sequence. The intervention model seeks to disrupt this damaging biological cycle by focusing on the promotion of relational health. Nurturing positive, safe, stable, and nurturing relationships, SSNRs, acts to buffer the physiological effects of adversity, thereby promoting resilience. By supporting positive caregiving behaviors, the system targets core developmental pathways, aiming to shift the probabilities of lifelong health and learning outcomes away from risk and toward adaptive functioning. Socio-economic and ethical rationale. Beyond the science, the mandate for EI is justified by compelling socio-economic and ethical considerations, especially within a developing economy. The explicit operational goal articulated in the District Early Intervention Center, or DEIC, guidelines is to mitigate the lifelong consequences of disability. It's a progression. A primary biological defect leads to functional disability, which, if unaddressed, results in a permanent handicap imposing a severe burden on the family and society. The DEIC's purpose is defined as early detection and intervention aimed at minimizing this functional handicap. This necessitates deep integration with educational, social, and eventually vocational sectors to ensure the child can participate fully in society, moving beyond initial clinical management. Furthermore, early childhood development, ECD, outcomes are highly stratified by socioeconomic factors. Unfavorable developmental outcomes are highest for children residing in poor, rural households where parents may lack education. Socioeconomic inequality acts as a clear barrier to accessing crucial resources like pre-primary education and early intervention services. The universal nature of the RBSK program is a strategic equity measure intended to dismantle these barriers. By providing comprehensive screening and guaranteed follow-up care, free of cost across all Anganadai centers, AUCs, and government schools, the program attempts to ensure that access to developmental opportunities is universal. This is a targeted effort to reach vulnerable populations disproportionately affected by developmental delays associated with disadvantaged socioeconomic positions. Policy and legislative framework. The entire Indian early intervention system is anchored by a powerful and modern legislative mandate, the Rights of Persons with Disabilities, RPwD, Act, 2016. The Rights of Persons with Disabilities Act, 2016. The RPwD Act establishes the legal and ethical foundation for all disability-related services in India, simultaneously aligning domestic law with the United Nations Convention on the Rights of Persons with Disabilities, UNCRPD. The Act provides a clear statutory basis for early intervention, requiring government measures to ensure children with disabilities, or CWDS, enjoy rights equally with others, including the right to express their views based on their age and disability. Specifically for our purpose, the Act mandates provisions for the early identification and prevention of disabilities. Crucially, the RPwD Act requires the establishment of preparatory schools and support systems geared towards inclusive education, ensuring children with disabilities attain school readiness up to the age of 6 years. This legal mandate defines the systemic responsibility for ensuring that the early intervention system successfully feeds children into the inclusive educational pipeline. The Act also significantly expanded the definition of disability, placing a broader and more complex mandate on the early intervention sector. This expansion notably includes chronic pediatric conditions, such as hematological disorders like hemophilia, thalassemia, and sickle cell anemia. The inclusion of these conditions, which necessitate early, complex medical management, moves the scope of early intervention beyond traditional neurodevelopmental and motor disorders. This places a substantial responsibility on the rehabilitation sector to seamlessly integrate long-term specialized medical care with developmental support. National Program Architecture, RBSK and ICDS Convergence. The Rashtriya Bal Swasthya Karyakram, RBSK, provides the large-scale, operational structure for implementing the RPwD Act's mandates for early identification and linkage to care. RBSK is an innovative, systemic initiative under the National Health Mission, NHM, designed to provide child health screening and early intervention services. Its objective is to reach approximately 270 million children, spanning from birth to 18 years of age, aiming to reduce mortality and manage the rising burden of non-communicable diseases and birth defects through timely intervention. The core of the program is its screening methodology, which focuses on 30 identified health conditions categorized into the famous 4 dimensions or 4D framework. 1. Defects at birth, which includes neural tube defects, cleft lip and palate, developmental dysplasia of the hip, congenital cataract, and congenital heart diseases. 2. Diseases, covering common childhood illnesses and conditions such as otitis media, rheumatic heart disease, reactive airway disease, dental caries, and convulsive disorders. 3. Deficiencies, focused on high-burden nutritional issues like severe acute malnutrition, or SAM, and severe anemia. And 4. Developmental delays including disabilities, which covers sensory deficits, specifically vision and hearing impairment, and neurological disorders, such as neuromotor impairment and cerebral palsy. This structured, targeted approach allows the system to gather countrywide epidemiological data on the 4DS, which is critical for future planning and customizing area-specific services. The implementation of RBSK is critically dependent upon strategic convergence with the Integrated Child Development Services, ICDS, scheme. ICDS provides a massive, widespread network of Anganadai centers, AUCs, that deliver essential services including supplementary nutrition, preschool education, and health check UPS for children up to 6 years of age. RBSK utilizes the AUCs for community-based screening of the target age group, ensuring services are extended to rural areas and urban slums. By embedding screening within the established ICDS structure, the framework maximizes developmental reach and acts as an efficient equity tool. Component 1, Screening and Primary Identification. The first component of the early intervention model is the multi-tiered screening strategy, designed to maintain a continuous surveillance system from birth through adolescence. Multi-tiered screening strategy. The RBSK screening strategy is tiered based on age and location to ensure continuous surveillance. First, perinatal and home-based screening from birth to 6 weeks of age. Comprehensive newborn screening for birth defects is initiated by medical professionals at the delivery points. Following discharge, the accredited social health activist, ASHA, conducts follow-up screening of newborns and infants during home visits, which are part of the home-based newborn care or home-based care for young child programs, as part of early childhood development monitoring. Second, community screening from 6 weeks to 6 years of age. Preschool children attending OCS are screened biannually by dedicated mobile health teams, MHTs. Third, school screening from 6 to 18 years of age. MHTs continue the surveillance system by monitoring the health of government school children enrolled in classes 1 to 12 once a year. The frontline workforce, ASHA and OROLs. The entire screening cascade relies critically on the performance of the frontline workforce, the ASHA and the Anganadai worker, A. These workers are uniquely positioned within their local communities to identify and mobilize beneficiaries. Their core responsibilities include conducting home visits, promoting health and nutrition, monitoring monthly growth of children under 6 years, and promoting institutional delivery and immunization. Specifically for developmental surveillance, the ASHA worker is mandated to check for developmental delays during routine home visits at 6, 9, 12, and 15 months of age. The OS follow scheduled timetables and counsel parents to encourage the improvement of the child's developmental status. While this high-frequency surveillance model is intended to reduce health disparities, its efficacy is fundamentally constrained by operational realities. OS report challenges that severely impact service delivery, including high workloads, a lack of dedicated training for skills upgrades, and insufficient infrastructure and play materials necessary for robust early stimulation. This persistent mismatch between mandated responsibility and resource capacity is a critical point of systemic fragility in the primary detection component. Screening tools and referral protocols. To facilitate mass screening by the OS and teachers, the system utilizes simplified observational tools. For example, screening for children aged 2 to 6 years involves a 25-question tool administered to the caregiver across 5 developmental areas. A referral flag is raised if at least 3 out of 5 items in a domain show signs of delay or disability. Since this primary screening uses non-specialist and proxy-reported information, the reliability of the entire system depends on a seamless upward referral for expert confirmation. Children flagged by the MHTs or frontline workers are referred to the primary health center or community health center level and then onward to the District Early Intervention Center, DEIC, for holistic assessment, investigation, and definitive diagnosis. Component 2, Diagnostic, Management, and Tertiary Services. The second, and arguably most specialized, component of the system is the District Early Intervention Center, DEIC, model. The District Early Intervention Center, DEIC, model. The DEIC, established at the district hospital level, functions as the central hub and clearinghouse for the entire RBSK program, acting as the second tier where preliminary findings are confirmed, managed, and linked to tertiary care. The DEIC provides comprehensive services including early identification, holistic assessment, investigation, diagnosis, and specialized intervention. The center focuses primarily on core services for children below the age of 6, managing conditions ranging from birth defects to diseases and deficiencies. Critically, the DEIC plays a vital role in providing referral linkages to tertiary hospitals for specialized surgical or intensive medical treatment when necessary. This referral process, including tracking and follow-up, is supported by funding provision under the National Health Mission for Management at the tertiary level, ensuring financial barriers do not halt definitive care. Multidisciplinary and transdisciplinary team approach. The complexities inherent in managing the 4Ds necessitate an interdisciplinary approach housed within the DEIC. The center is staffed by a multidisciplinary team, including medical specialists like a pediatrician or medical officer and a dentist, therapeutic specialists such as a physiotherapist, occupational therapist, and speech and language therapist, along with a special educator and a social worker or psychologist. To maximize comprehensive understanding and resource efficiency, the service model promotes a transdisciplinary approach, where team members share information and role-specific responsibilities. The ultimate goal is to define a detailed educational and therapy plan, including an Individualized Family Service Plan, IFSP, based on the comprehensive needs of the child and family. Recognizing the constraints of placing all specialists in every facility, the DEIC core team is responsible for providing supportive supervision and capacity building to train multi-skilled community personnel. These trained personnel then deliver decentralized, domain-specific services closer to the child's home at the block or community level. Specialized therapeutic and educational interventions. The DEIC provides targeted medical and rehabilitative services essential for minimizing long-term functional disability. Core services include pediatric dental services for early childhood caries, pediatric orthopedic services for conditions like clubfoot and developmental dysplasia of the hip, or DDH, and end services for hearing and ear problems. Dedicated units focus on therapeutic interventions for communication deficits. For example, speech therapy incorporates essential components like auditory training, which includes the awareness, detection, and discrimination of sounds, to facilitate language development, recognizing the child's need to be aware of environmental and speech sounds. The special educator plays a pivotal role, performing assessments of pre-academic skills, which include foundational concepts like shape, size, color, and numbers, based on age-related development. This assessment forms the basis for preparing a detailed, individualized education program, IEP. For nonverbal children, alternative augmentative communication systems, such as the Picture Exchange Communication System, PECS, are utilized to support social communication. This emphasis on pre-academic and preparatory schooling is mandated to ensure children are ready for inclusive education as per the RPwD Act. Finally, a key element of the rehabilitation mandate is the provision of assistive technology and devices. The system ensures linkage to resources for equipment related to hearing, vision, mobility, and learning, supported by schemes like the Assistance to Disabled Persons for Purchase or Fitting of Aids and Appliances, ADIP, scheme, and includes high-cost interventions such as cochlear implants. Component 3, Family-Centered Care and Delivery Models. The entire early intervention model rests on a philosophical commitment to a parent-centric approach, recognizing the family as the single most important agent for sustained intervention. Principles of Family-Centered Care, FCC. The primary psychological support provided by the DEIC team involves counseling and designing learning environments and activities that families can seamlessly integrate into their daily routines. Parents are actively coached to become therapy assistants to deliver specialized services within the child's natural environment. This strategy is designed to maximize the transfer of learning and ensure stability in upbringing practices. It's a resource-efficient method that also significantly improves family competence, self-efficacy, and satisfaction with care. The partnership model is crucial and involves shared decision-making, SDM, ensuring that parents are actively included in customizing the child's health care. This collaborative approach aligns medical recommendations with the family's context, values, and priorities, fostering a sense of shared responsibility rather than simply making parents passive recipients of services. Furthermore, the medico-social worker facilitates linkages to resources aimed at building social relationships, such as self-help groups, parent associations, and sibling networks, which provide essential psychological support and empowerment for both the child and the parent. Decentralization and community-based intervention. The practical constraints of specialist availability across the vast Indian geography necessitate a hybrid, scalable delivery model focused on maximizing community reach and specialist time efficiency. The functional strategy involves separating the resource-intensive diagnostic confirmation, which is centralized at the DEIC, from the ongoing intervention delivery. This intervention is decentralized, often carried out at the block or community level or even in the child's home, delivered by multitasking community personnel who serve children close to where they live. This approach is essential for achieving service coverage across large geographic areas. Evidence from studies conducted in Indian low and middle income country, LMIC, context supports the efficacy of caregiver-mediated interventions. For instance, studies demonstrated that coaching caregivers, often adapted from evidence-based models like social ABCs for autism spectrum disorder, significantly improved child responsiveness and increased parental fidelity in implementing strategies, particularly for children under 3 years of age. This finding validates the resource-efficient strategy of empowering parents to be the primary intervention agents. Non-governmental organizations, or NGOs, are also recognized as crucial partners in supplementing government efforts, especially in delivering specialized rehabilitation services, particularly in areas like mental health and specialized education, or advocating for curriculum changes and policy inputs. Systemic challenges and strategic recommendations. The potential success of the RPwD-mandated RBSK framework is structurally threatened by chronic implementation issues, primarily related to fiscal, human resource, and coordination deficiencies. This is where the experienced clinician must move from understanding the ideal model to grasping the operational realities. Critical implementation constraints. First and foremost is the issue of fiscal and human resource deficits. Public expenditure dedicated to children remains chronically insufficient, leading directly to budget constraints and resource deficiency across the system. This fiscal deficit compromises the ability to fund necessary specialist positions, leading to a critical human resource crisis. The shortage of dedicated, qualified early childhood education educators and special education teachers is particularly acute. This severe pressure on existing staff results in insufficient time for supervision, training, and capacity building for frontline workers. Furthermore, frontline centers, such as the Anganadi centers, often lack the foundational infrastructure, proper facilities, and developmentally appropriate teaching or play materials needed for high-quality early stimulation. This deficiency compounds the risk that families will bypass the system, leading to children entering school without adequate school readiness. This creates a detrimental self-reinforcing dynamic. The persistent shortage of qualified staff and specialized resources compromises service quality at every level. This reduced quality diminishes parental trust and utilization, which in turn reduces the justification for increased public spending. Low investment leads to low quality and low usage, perpetually undermining the overall return on investment for early intervention programs. Bridging intersectoral gaps. The multi-agency nature of RBSK, relying on cooperation between health, women, and child development, and education, makes the continuity of care exceptionally vulnerable to coordination failures. The core of the early intervention process requires seamless movement, from screening under women and child development to clinical confirmation and management under health, and finally to specialized educational and social rehabilitation under education or the Ministry of Social Justice and Empowerment. However, there is a systemic lack of formalized intersectoral mechanisms and communication among these key pillars. This organizational fragmentation is detrimental. A failure in coordination at any point significantly increases the risk that children identified with developmental issues will be lost to follow-up, thereby negating the entire early detection effort and undermining the inclusion mandates of the RPwD Act. Finally, while the RBSK program is mandated to utilize software for screening, tracking, and reporting with the strategic goal of capturing countrywide epidemiological data on the 4DS, realizing this goal is essential for effective long-term planning. Detailed prevalence data on specific conditions, especially rare diseases and deficiencies, allows for customized resource allocation and the targeted deployment of area-specific services. Strategic recommendations for enhanced delivery. The path forward requires specific, focused interventions that address the structural vulnerabilities we have just outlined. First, sustained fiscal prioritization and protection. A mandatory, non-lapsable budget must be instituted for early childhood development and early intervention spending, dedicated to resource acquisition rather than relying solely on flexible National Health Mission allocations. This protected funding must prioritize the hiring of specialists, continuous recruitment of specialized human capital like special educators, and necessary investments in infrastructure and specialized play materials at the Anganadi Center level. Second, decentralization and tele-intervention. We must accelerate the strategic establishment of block and community early intervention centers to maximize the reach of the hybrid service model. Furthermore, leveraging digital health infrastructure to promote tele-intervention aligns perfectly with family-centered care principles and utilizes technology to bridge geographical barriers, thereby optimizing the delivery of specialist guidance to remote caregivers. Third, mandate high-fidelity capacity building. Implementing robust, continuous professional development programs for ASHA and AWA workers is non-negotiable. This training must focus on advanced, domain-specific skills in developmental surveillance and parent-mediated therapies. This critical workforce must receive standardized and continuous supportive supervision from DEIC specialists to ensure the quality and fidelity of decentralized care delivery. Fourth, enforce RPwD Act compliance through intersectoral accountability. Formal, ministerial-level accountability mechanisms must be established to ensure mandated coordination among the health, women, and child development, and education ministries. This must include a mandatory referral tracking system that monitors the child's progress from diagnosis at the DEIC through the entire rehabilitation continuum, guaranteeing successful linkage to educational placement and vocational support, thereby fulfilling the comprehensive mandate of the RPwD Act. Conclusion, key take-home points. We have covered a tremendous amount of ground, moving from the microscopic world of synapses to the macroscopic scale of national public health policy. To consolidate this critical knowledge, here are the 3 essential take-home points for every clinician involved in child health. Number 1, the neurobiological imperative. Early intervention is mandated not by bureaucracy, but by the neurobiological reality that the period from birth to 3 years represents the optimal, critical window of synaptic plasticity, making intervention profoundly more efficient during this time than later in life. Number 2, the 4D framework and the DEIC hub. The operational framework, RBSK, is built upon the detection and management of the 4 dimensions of health conditions, defects at birth, diseases, deficiencies, and developmental delays. The District Early Intervention Center, DEIC, is the multidisciplinary, centralized hub for definitive diagnosis, specialized intervention, and critical referral linkage to tertiary care and long-term rehabilitation services. Number 3, the crisis in continuum of care. The system's greatest vulnerability is the fragmentation between the health, women, and child development, and education sectors, compounded by a chronic shortage of specialized human resources and fiscal deficits. Successful clinical follow-up is entirely dependent on ensuring the seamless referral tracking and intersectoral accountability required to move a child from detection at the community level to their final inclusive educational placement. Understanding this infrastructure and its challenges is the first step toward improving outcomes for millions of children. The success of a child's developmental trajectory often rests on the ability of the system, and its dedicated practitioners, to detect and intervene within that fleeting, critical window. Thank you for tuning into this crucial discussion.